Now we're going to do lower extremities. Okay, now one of the things when you're looking at lower extremities, this is not just important, it's vital. If somebody comes to you with low back pain or has low back issues or difficult menstrual cycles or anything else, that's going to be sitting on top of a pelvis. If the pelvis is unstable, that means that it's because of long-term low back problems or anything going wrong with the extremities. This means if she can't dorsiflex, that means that she's going to walk with her pelvis, so that's going to destabilize it. So if you have somebody with an unstable pelvis, you have to absolutely check the tone of the calf, you have to check the biomechanics of the foot, you got to check the biomechanics of the knee, you got to check everything. Okay, does that make sense? Yes or yes? Okay, good. Good. So first off, what we're going to do, we're going to start off with the knee assessment, okay, because this one's the most important. Now the knee, you've got two muscles that guide the patella, and this is how you check for patellar tracking. Now you're going to grab the patella, and the patella is just right here. I'm going to grab it, and I'm going to pull down fairly. You don't want to push in. If you push in, that's going to irritate the infrapatellar bursa. So I'm going to contact, stabilize on the leg, and apply pressure down in an oblique fashion, not in at all. And then I'm going to say, does that cause any discomfort? Yes, a little or a lot? Little, okay. Then I'm going to grab this and pull this along. Does that cause a little bit of discomfort or a lot?
A little bit.
A little bit. See, if you have a muscle imbalance, and we've got vastus medialis and vastus lateralis, if I'm able to pull this down really, really hard, and she says, ow, okay, that's what you're looking for. You're not looking for, yes, it's a little bit of discomfort. Because if the vastus medialis is weak and it allows you to push it too far, that means that her patella is constantly going off on this side. And typically, if it's vastus medialis that's weak, she's going to have more knee pain when she goes downstairs or down a hill. If vastus lateralis is weak, she's going to have more pain going upstairs or going up a hill. So those verbiage, downstairs, vastus medialis, also if you apply pressure from the medial to lateral, superior to inferior direction, if that's weak, you got to suspect that it's a weak vastus medialis. If you apply pressure where you're driving it in this direction, okay, and she says discomfort on the lateralis, it's going to be vastus lateralis. Also, you need to check the medial meniscus, because since the ligaments, the knee doesn't work like a hinge. You always got to look at the knee that it works like a screw. It actually pivots on the lateral aspect and moves twice as much on the medial aspect. This is why if you see someone wearing a knee brace with a hinge on both sides, that's an absolutely contraindicated knee brace. That's a stupid knee brace. You need a knee brace with two hinges on the inside and one pivot point on the outside to allow that this knee doesn't move like a hinge, it moves like a screw. So that's vital that you have that awareness. Now typically if there's been long-term knee problems, that means that the medial meniscus, and the meniscus is sitting on top of the tibia, and this giant tibia plateau, and it looks kind of like heavy Tupperware, where it guides the movement of the femur on it, okay? It guides that movement. So it's going to be strained a lot. Now I'm going to show you how to do a non-surgical repositioning of the meniscus. Now the meniscus, what you want to do, you're going to distract the joint. So you lock the ankle in with your legs. You can distract, so I'm leaning back to open up that knee joint. Now this doesn't hurt at all. But anyone with long-term knee problems, what you're going to do is you're going to palpate with your thumb at the junction. You're going to feel the femur up here. You're going to feel the tibia down below, and it's right in the middle, and that's going to be the tender area. And what you do is you apply pressure, medial to lateral, right along there while you're distracting. So I'm opening up the joint, flexing the joint, putting pressure in on the meniscus, and that's going to have a repositioning of the medial meniscus. What's neat about this, if somebody's had long-term knee problems, doing this just about, say, 15-20 seconds, they're going to notice a pain relief almost immediately. But in order to correct the muscle imbalance, to correct the medial meniscus, you also have to look to the nerves in the spine. No one ever is going to have an incorrect firing of patella tracking muscles if they have healthy nerve supply in the spine. So the people are going to have an incorrect firing of the vastus of the patellar tracking. They're going to be sedentary lifestyle or they're going to be athletes, one of the two extremes. Now here, rise up, swing your legs around that side. We're going to demonstrate the rehab for patella tracking. If she has vastus medialis, what you're going to tell her is, what I want you to do is you're going to do extension exercises. So we're going to demonstrate that she has a weakness of vastus medialis on here. She's going to do extension exercises like this, but this foot is going to be turned out. And then you want her to exercise just like that. So demonstrate. Perfect. Good job. Now, the reason you want to work both legs is because you get that cross-crawl mechanism and that gets equilateral firing and you're going to heal it faster. Now, let's say she had vastus lateralis that was weak. Can you imagine what you're going to do there? Oh my gosh, she is good. She must be a doctor. Exactly. And you do this for about 5 to 10 minutes. It's going to be ideal. Now, let's say that you've had some meniscus damage and you want to regrow the meniscus or regrow cartilage. Yes, you can regrow cartilage. Yes, you can regrow meniscus because it's living tissue. So I did that drop because I wanted you to hear the weight. Okay, this right here, these are about 7.5 pounds, 15 pounds a pair, which is going to be ideal. Now what happens is, and this is how, if you have cartilage that's damaged, if you have a meniscus that's damaged, this is how to regenerate the cartilage or regenerate the meniscus. The most frustrating thing in the world is when a patient comes in and they say, gee doc, you know, my doctor says that I have bone on bone. You can confidently say if they can bend it, it's not bone on bone. Does that make sense? Okay, if a guy comes in and says, gee doc, the doctor said my knee is bone on bone. If they can't bend it, you might say, he might be right. Okay, if they can bend it, you can regenerate the cartilage. So the mechanics of this are, you want to distract that joint, okay, without compressing it. See, every time you walk, when you walk, that leg flies in the air, and that creates a negative pressure. When you stand on it, it creates a positive pressure. So just the act of walking creates a negative, positive pressure. And that allows a pumping action, so that allows the superfiltrated blood, called synovial fluid, to get inside of that joint. So, in order to rehab the knee and regenerate cartilage, first off, you got to clean the blood. You got to make sure that they got a healthy diet. This is why diabetics, people with bad diets, actually are going to have more large joint problems. Okay, and obviously, if you treat it with a chemical like Advil, Motrin, Tylenol, all of those drugs inhibit proteoglycan production, which is the building block of cartilage. So any doctor out there prescribing an anti-inflammatory for a joint problem is completely ignorant of the negative effects of the joint, of that drug on the joint. Does that make sense? So what we want to do, we want to distract the joint. So what you're going to do is you're going to apply a weight. Again, you got to do it to both, even if one is just affected, because you can have a one-leg symptom, never a one-leg problem. And then what you're going to do, so this is opening up the joint, you want her to move it just like that. Good. Just like that. And that's even a little too much. A little bit less. Perfect. Just like that. So again, she's opening it up. Cross-crawl mechanism. She's not extending it huge. Okay, so because we don't want to strain the muscles, we want this as a ligamentous exercise. Now, to facilitate it even faster, we want to do moist heat on the knee. Why? Because moist heat is going to increase blood supply to the knee. It's also going to be increasing the metabolic processes of the knee. It's also going to be increasing lymph flow. And we want more blood to the... How come you stop? Keep going. You're lucky I don't have a ruler. So what you've got to do the distraction, do the moist heat. And people that have had the worst knee problems in the world, just by doing this for about 10 minutes, they're going to notice a difference immediately. immediately. And you know, you got to figure the average adult, they can tolerate between 5, 8, maybe even 10 pounds. Larger adult, you can do 10 pounds per leg. Smaller kid, maybe just 5 pounds per leg. And this is absolutely, you will see on x-ray, you're going to see on symptomatology how the knee joint can regenerate, and that quick. Now, and that's typically about 10 minutes a day, moist heat. It takes, for symptom relief, you're going to notice it almost immediately. For long-term symptom relief, it may take between 6 months and 4 years to regenerate the cartilage. So they're going to do this every day for about 4 years if they're very, very chronic. But I got to tell you, in 4 years, would it be nice to have a natural new knee or a knee replacement that only lasts 10 years? Okay, so let's just, you know, do normal stuff. Okay, go on your back, please. So that's how to assess the knee. That's muscle, that's patellar tracking, muscle imbalance, medial meniscus, and now we're going to assess the calf. This is super, super, super important. This has to do with an unstable pelvis. This has to do with long-term low back pains. If you do not pay attention to the calf and the biomechanics of the foot, you are never going to have this person have a permanent recovery. Now, when you look at this, when you look at the calf, on the back of it, remember the name of the Achilles tendon? It's called triceps surae. That's because inside of this muscle is the soleus muscle. And inside this muscle on the back, that muscle has a pump. And it's a pump every time this foot dorsiflexes and plantar flex. This bone on the outside, called the fibula, moves up and down. So you look at this like if you had x-ray vision on. You've got one bone called the patella that holds up the weight of the body. The other bone is just for muscle attachments. So if this joint doesn't work correctly, okay, and it should be listed as a joint, but it's not. So every time that moves up and down, you're getting the pumping action of the soleus muscle. So what happens in chronic why? Well, first off, think about this. Why would God put a soleus muscle or a pump in the leg right here? First off, we got the largest muscle group here that's going to require a tremendous amount of oxygen to burn so we can run away from danger. We got the largest joint in here that's going to require a tremendous amount of water. Plus, we got the foot down here, which is the furthest point away from that heart that's way up there. So this pump has got to work. It has got to work. So how we assess it, when we look at normal muscle ratio, it should be 10 to 1. Or the posterior muscles on the back should be 10 times stronger than the anterior muscles. Typically, okay, people that wear high heels, okay, toe walkers, athletes, you'll have a 15 or 20 to 1 ratio. On a 15 to 20 to 1 ratio, the body realizes that the anterior aspect is going to start tearing, so it lays down cross-fiber adhesions. These adhesions can become so great that they actually cause a fracture or a splinting of the shin, called shin splints. Shin splints, isn't that cool? Okay, good. So it doesn't come from running on concrete or running on any other surface. It comes from a muscle imbalance. Okay. Now, there's two ways to check this. One is dorsiflex and plantar flex, and with your hands in between the two muscles. And you should feel there's pretty reasonable motion there, there's no motion there, there's no motion there, and there's actually pretty reasonable motion there. So those areas of less motion tend to be where the scar tissue is, and that's limiting it. And this is also going to be involved in bunion formation and flat feet, unstable pelvis, everything. So you got to pay attention to this. Now, two ways to fix that scar tissue to break up the adhesions. One, if you've got more time than sense, you're going to do deep tissue work. Okay. The other, if you can do a variation. Now, I did this just out of, regular Harbor Freight tools. This is just a furniture end that applies a little bit of pressure. Pettibon makes one called a PT-LMS, which is fantastic. That also works on this. I like this one because it's variable and it has a cord on it. But what you don't want to do is if you do this on the tibia, that would be very uncomfortable. If you do it on the fibula on the side, you're going to fracture the fibula. Again, that would not be good, okay? So what you want to do, you want to feel the tibia coming in. You're going to go right next to the tibia, and I'll put my finger right next to it and apply a little pressure. So my fingers are right there guiding it, okay? I would rather have my finger get squished than her tibia or fibula, because we want to go right in that interosseous space I'm just going to do a couple of passes, and then we're going to see that it feels more even, and then I'm going to double check. Sure enough, she's got good motion all the way around. She's missing a lot of dorsiflexion there, so I know that she does have, problems with the pump coming down, and we're going to go over how to assess that. But first, let's look at the fibula. Because if the fibula is subluxated, it can only subluxate posterior or anterior. The way you're going to look at it is to palpate it, and you're going to look for tenderness. You're going to compare it with the non-affected side with the affected side, or the tender side. And if it feels more anterior, then it's gone anterior. If it feels more posterior or depressed in there, then it's gone posterior. So a posterior fibula will feel, compared with the non-affected side, it's going to feel more posterior, and it's going to be swollen and tender. So the adjustment for the posterior fibula is you're going to contact with your thumb on the posterior aspect of the proximal aspect of the fibula and the anterior aspect of the distal fibula. And what it's going to look like is it's going to be a shearing force up here and down here. So it's going to be a small scissor-like action just in that fashion. Okay, very, very easy. If it's gone anterior, so again, it's just in that fashion. So it's very, very simple procedure. If it's gone anterior, how it's going to present means it's gone more forward. You can distract it out, back it up, and apply pressure where I'm just squeezing my hands together just in that fashion. So it's super, super easy and very, very, very simple because I'm distracting the joint and the joint's opening up, so it doesn't require much effort. Now, when we look for the ankle, because once we've paid attention to this, we have to look at the most common subluxated bone in the ankle is going to be the talus. So you've got this U joint coming down here that's composed of the fibula and the tibia. And this bone comes in the middle that rocks back and forth, and that's the talus. Typically, it's going to be subluxated in this fashion because the anterior talofibular ligament is the most commonly sprained ligament of the body. That means that it's an inversion sprain. That means that talus comes this direction. Does that make sense? So how you would assess this would be palpate on both sides, and sure enough, this one does seem a little bit more anterior. You probably twisted this one a few years ago or so. So what we want to do, again, we want to contact it and back it up. But what I'm going to do, I'm also going to contact the calcaneus, so we distract the whole joint. So, and then I'm moving it in the opposite fashion. So contact the talus, because remember, it's gone in this direction. We're going to contact it, back it up, distract out, and turn the foot. And so the thrust is going to be straight down, just like that. So straight, superior to inferior. Now, contraindicated would be if she had a hip replacement, or if she had a knee replacement, or if she's in acute agony of the low back. You can't do that. Okay, you can't do the standard set. What you can do is you can dorsiflex, lock it in, and use an activator. You can also use your thumb to drive it down. There's a lot of variations on here. Just know that what you want to do, you want to dorsiflex or externally rotate that foot and then drive pressure into it. Okay? Now, the calcaneus, which again, that's also very commonly subluxated, you check by comparing dorsiflexion, and if it feels restricted, you can come back, and then you always want to compare the unaffected, go in next to the triceps serrae or the Achilles tendon and see if there's an increase in swelling or a resistance. That can indicate that the calcaneus is jammed. Now, the calcaneus only jams up that way because when she's jumping, that's the direction that the calcaneus goes. So what you want to do, you're going to hook the calcaneus or hook it in that fashion. I grab the foot so we're distorting it, or I'm leaving the foot in a neutral position, so I've got something to hang on to, which makes the calcaneus a little bit more prominent. Hook that, distract down, and then it's an impulse superior to inferior. Very, very easy, but you got to do pretty hard. Okay, now I'm going to demonstrate one other way to do a calcaneus on a very, very large person. Okay, so this is a smaller chiropractor that's working on a very large person. So here, go in your tummy. Now this one is a variation on a very, very large person. What you want to do, again, the calcaneus is going to be jammed up like that, and what we're going to do is hook it and distract the joint. And again, you don't want to do this if there's a knee replacement or a hip replacement or anything like that. You're going to rest. I better transfer this over here. You're going to rest the calcaneus on your shoulder. And then what I'm going to do is I'm hooking it so the line of drive is going to be back in this fashion. So I lean back, and then it's going to be a small thrust in that direction. Okay? And you just heard the cavitation. It works really nice, and it's very, very comfortable. Okay? Don't worry about the smell. Okay, no. I'm totally kidding. Her feet are clean. Okay, but when you do that, okay, you can see you're leaning back. The position of the doctor is hugely important. You want to be distracted down. You want to lean back so you're not straining your back, and then it's a thrust with your legs up. So you're not using your arms. And this is to do with a very, very large person. So the doctor's safe and the doctor's not straining. Okay, does that make sense? Okay, good. Flip over, please. I know, isn't that a cool adjustment? Okay, now, let's look at bunion formation. Okay, bunions can be healed very, very quickly. Bunions only come from weak intrinsic muscles of the foot. So what happens is, you can see a little one starting to form here, but this doesn't come from bad shoes, high heels, or hereditary. Okay, none of that stuff is true. What happens is the muscles inside of the foot become weak. Why do the muscles become weak? Because of long-term low back problems. This is sedentary lifestyle or long-term back. So you've got to pay attention to the spine first, because what happens is this comes from weak intrinsic muscles of the foot. That muscle should be there, and that would pull this toe over, and then what do you got? You got a normal-looking foot. Okay, so what we first got to do is restore nerve supply to the foot in order to regenerate a healthy foot. Okay, so we got to adjust the low back. And then we also have to make sure that the pump works, because if this soleus isn't getting healthy oxygen to it, it's kind of like putting a tourniquet on the foot and saying, okay, hun, go walk on the beach now. Okay, that just doesn't make any sense. So we have to restore nerve supply first, and then the foot's going to work fine. Okay, does that make sense? So first off, for assessment of the foot, she's going to have to walk barefoot in grass, dirt, or wet, hard sand. And the reason is, first off, if you have feet in direct contact with the earth, there's an electronegative charge on the earth that's going to detox the body. Second, if the feet are in contact with the earth and it's not shielded with a foot brace or shoe or anything else, the foot moves in a fashion where every joint in here moves. I mean, all 26 of these bones is going to move, flex, turn, twist, everything. It's going to be fantastic. And that, when it's flexing under force, you're going to start to renew the intrinsic muscles of the foot. Okay? But first off, what we're going to do, we're going to assess to see if this calf is working correctly. And how you do that, you want to push up on it. Now, if you just push like this, the doctor's going to hurt his back. So what you want to do is you put your hands on your thighs, and I lean forward. So I'm pushing up very, very hard, almost hard enough to move her body. And I'm pushing up so hard, and you'll see that the foot is barely bent to 90 degrees. Anybody's foot that barely bends to 90 degrees when I'm pushing up that hard means that she's got a problem with the calf. That's one of the reasons that she's starting to get formation of the bunions. So now we use this high-tech tool, which is a ankle extension exerciser. Yes, this is what I pass out to my patients. It actually has directions on it and my logo. So here, rise up. Okay, stand there, face me. Okay, what she's going to do is she's going to put your foot on the ground with the ball of your foot on that. Now, you'll see her foot is at a little bit less angle than mine. Leave the heel on the ground and bend the knee. Okay, now, her knee should come over the toe. In normal, the knee should come way over the toe. Okay, in hers, with the incorrect ankle, her knee is barely bending. So now she's got to hold this for 1 minute, twice a day. 1 minute twice a day. Now, as long as you're adjusting the nerves in the back, you're taking care of the interosseous membrane adhesions, you're making sure that the ankle and calf are well adjusted, her knee should be over the toe, and she should have normal function in about 2 months. Okay? She's going to continue to do this for month after month after month because she has some type of lifestyle, like maybe she's a student, homemaker, something. But this way, since she's a woman and she might want to wear high heels, which is great because it attracts guys and it makes the legs look longer and the butt stick up, this right here, she'll be able to wear high heels till she's 90 and never have a negative from it. Okay, does that make sense? Because the only reason the high heels cause a negative is because it causes the pump to not work correctly and the pelvis to not work correctly, and then that destabilizes the low back. So this way you do this, you can wear the high heels. Does that make sense? I'm telling you. The chiropractors that say, look, don't wear high heels, they're going to be single quick. Okay? That's the lower extremity. Okay, the last joint up here, is the top of the femur. Now, to assess this, and this is really, really common in people that kickboxing, martial artist, or sitting. Again, you got to look at it as somebody with a sedentary lifestyle. If you can put on those x-ray glasses with me, this is the top of the pelvis. There's a muscle that attaches to the lower back that comes in and attaches on the inside of the thigh. And that's the psoas. Okay, and there's a lot of techniques for loosening up and relaxing the psoas. Honestly, the best way to do it is to adjust the low back, get pressure off of it, and then find out why it's tight. Because if you're sitting a lot and the leg is bent like this, and this is her in the sitting position, you can imagine that psoas muscle is going to be shortened. Okay, does that make sense? So what you want to do is first find out why. Now, typically, the femur goes anterior, and that has to do with the position of the pelvis and its location. So what you can do is apply pressure, go on one side, go on the other side, and when you're doing this, make sure your fingers are going lateral, always. You don't want them going medial because that's just not appropriate. So you apply pressure, and if there's one side that's more resistant than the other, typically it's gone forward. And you could ask her if you've done kickboxing a lot, because that will cause that hip to go forward. A sedentary lifestyle, I happen to know she's a student, so that means she's sitting a lot, and that can also drive it forward. So the way to set this, ideally you're going to use a drop table. And the drop table is going to be set very, very light, so it's going to drop down, and what you do is you set it, you contact it, and drive it down. Now there's also, and this is a rare finding, this is something, when you look at the pelvis, the pelvis comes together at the Pubic Symphysis. Occasionally, the acetabulum and the femur can mimic a Pubic Symphysis adjustment, and this one's really, really common. So this is how you find it, because you don't want to go searching for it, particularly on a girl, or a female patient, because let's say they've just given birth. Again, they've got that hormone that relaxes all the ligaments, that can damage the pubic symphysis. Let's say they've had some type of injury where the pelvis is subluxated as well, or they have an unstable pelvis. You've got to pay attention to the pubic symphysis along with paying attention to this area. So what I would tell patients is, you've got a bone comes right around the middle. What I want you to do is put your fingers right on it. So it's right there. So what I'm going to do is contact with a flat hand on the abdomen, and I'm going to come down right there on the pubic symphysis with the heel of my hand, so I'm far away from it. And the way to assess it is you're going to assess to see if it's tender, If it is tender at all, and I'm applying pressure in this direction, not direct into the abdomen, that would be uncomfortable. I could also tell her she has to pee. No. What you want to do, and this is to adjust that pubic symphysis, what you're going to do is you're going to use the legs to adjust it. And what you're going to do, you're going to pull the legs apart just about that far, not very far at all. But you're going to want her to squeeze her legs in as tight as she can. She's going to squeeze it in tight, and when I distract it, that's going to open up that pubic symphysis, and literally you will hear an audible, Okay, so what I want you to do is squeeze your legs together really hard, really hard, really hard, really hard. Good. just like that. So it's very, very simple. And typically you can do this a couple of times, and I'm going to demonstrate it one more time. Squeeze it together really tight, really tight. No, think of somebody you don't like. Really tight, really tight. Good. Okay, and just a little bit of pressure like that. Okay, and what that does, that gaps the pelvis. And there was a slight little audible there too. I know, isn't that interesting? I know. Okay, so anterior, you're going to drive it down forward. Okay, and then if it is forward, you got to check to see if there is a psoas, and there's multiple stretches that you can do for the psoas. Okay, and my favorite one is the lunge. Okay, so if you'll stand up, stand there, face to your left. The stretch, like let's say this psoas was tight, what I want you to do is you're going to put that leg back, posterior. Okay, you're going to lock your left leg. You're going to turn your pelvis so it's forward. You're going to lean back a little bit, and you're going to bend your right leg. So you're going to bend forward just in that fashion. And this, what this is doing, this is dropping that femur back posterior, stretching that psoas muscle, and it's going to be ideal. And if she can, you know, everyone in patient, they're going to say, oh yeah, I feel it right there, doc, right where I was hurting. I know, interesting. Okay, yeah, but still, you don't want to work on the muscles a lot, because muscles never respond, and this is where I'm going to get a lot of YouTube comments, muscles never react on their own. Okay, you want to work on the nerves that supply the muscle and look at the mechanics that she's doing during the day that's changing how that muscle increases in tone.